Okay, so thank you to all three presenters, and we'll be opening up for question. Haxby, I can't see any questions in the chat at the moment, but
yes, we have a couple of questions.
Oh, Curtin is here.
Not ones that are specific to these speakers, so we'll keep those on hand for if we have time to address them. But we certainly welcome anyone who's attending to type in a question into Q&A, and we'll select those and read them out for you. But for a start, can I just ask a question for Jay Xiang? And the question is about the measurements that you encountered in your review of movement patterns, and I'm wondering, if you think those measurements are precise enough, or are the measuring the domains of movement that are important to the generation of pain in this population. Do you think that the movement patterns that were being measured are the ones that are important, or what are your thoughts there?
Thank you very much, Haxby, for the question. So basically, as you saw in the presentation, the movement parameter that was most investigated would be knee adduction moment. Typically, that would be first knee adduction moment during gait, which is basically the first peak when the person loads their leg in early stance. It drops down a bit in mid stance, then back up again. So that's the second peak. And that's the outcome measure that's most investigated, largely because that particular parameter has been associated with structural progression of medial knee OA. Whether or not that is important, though, for in terms of if it's related to activity limitation or pain is another question. So it is quite unclear in the research if there is that relationship, even at the beginning, before someone receives intervention. There was a study that actually indicated that people with higher knee adduction moments had less pain, and they had severe knee OA. So it is quite questionable as to how relevant that particular outcome measure is, because there is diversity in the population, and basically someone with severe knee OA who walks with, if you like, bowed legs, knees facing outwards, and basically like that, and they actually can have quite low levels of pain. So should we modify that movement in that particular person? I don't know. They've already got severe structural deterioration, but maybe their pain is not so bad. Should they get surgery? I don't know. This is a discussion that you basically need to have with the patient around what they're wanting to achieve. So there's other things that I'd be personally looking at, which probably haven't been investigated as thoroughly. So you're looking at muscle bracing strategies. And as you saw, there was a study that was looking at the correlations between activity limitation and, pain and muscle co-contraction. And there was only one study, keep in mind, that had a moderate correlation between change in those two outcomes. So when someone is walking, for instance, if someone is loading a leg and they're bracing muscles around that area, and with increased bracing of the muscles, specifically hamstrings and quadriceps, as you load that leg, what also tends to happen is that you don't get as much knee flexion and kind of shock absorbing, which then increases the loading that you get. So what I tend to do in practice is basically try and get people to start to load their leg in a way that doesn't overly contract their musculature, just kind of responds to the ground reaction force appropriately, if you like. Maybe grades that activity, say, into weight bearing progressively. So if someone can't take a full step without experiencing pain, maybe they'll take a quarter step onto it, and load it up a little bit, then take a half step and eventually go to full single leg standing. So I'd be looking at basically muscle activity around the knee, as well as maybe that shock absorbing loading, and maybe also if they're pushing off on the hind leg at all. They'd be the ones that I'd be looking at, but I think the research has probably got to catch up, because it's been otherwise looking at, as I said, that knee adduction loading, which is related to structural progression, but maybe might not be so relevant for pain.
And can I ask, just following on, how do you think these data square with the evidence about the efficacy of unloading braces for realignment of the knee with an external brace device?
So I can definitely say I didn't look at those studies in as much detail. I did have a look at a couple of the systematic reviews in that space around bracing, or even shoe wedges to change the biomechanics, if you like. Keep in mind, those two particular interventions have been removed from the guidelines recently. In terms of recommendations, now no longer recommended. These studies in those areas are interesting in that some studies show that there is a change in movement in some, in terms of knee adduction moment, and not in others. I think there's maybe evidence that early on, after you take the brace off and reassess, that there is a change, but after they stop using the brace, then it stops having an effect. So I guess that comes down to what you're trying to achieve, what the patient wants, if they're willing to do an exercise program, if they're maybe putting a brace on their leg, and if that's sufficient and cost effective for them. But there is no high quality evidence, from my understanding, that something like that should be used.
Great, thanks, Josh-Young. And we've got a question from Samantha Bunsley, who notes that there are 3 great talks, but would you like to pose that question? Do you see it there?
Sure. So, yeah, Sam's posted a question for you, Tara, saying she loves your conceptual model, which we knew she would. What are your thoughts on how the constructs of confidence, fear, converge or diverge?
Hi, Sam. I know that we had spoken previously about how there might be this relationship between confidence and fear. And so I probably haven't spent a huge amount of time actually thinking about it, but I suppose just some of my observations of what's come up when I've been going through my data set. I would say that they're definitely separate, but they do seem to be associated, particularly in the symptoms domain and the structure domain. So there were a few, not a huge number, but a few people that reported that they were really fearful of those high pain levels that they were going to be experiencing. And there were some that were quite fearful of that feeling of reduced balance or unsteadiness that was related to a fear of falling. And also, I would say probably related to the structure domain as well. So there was some fear that was associated with the idea about the knee or the structural integrity of the knee being compromised. But I don't feel as though it really came up in the other 2 domains. It didn't seem to be something that featured that much in the knowledge or in the function domain as well. So I would say that there is some relationship, but they feel like they're 2 separate constructs to me. But yeah, we'll see. I'll have a bit more of a look, I suppose, through the data set and have a think about it.
Tara, can I just ask a follow-up question? Because I'm sorry, I wasn't clear from the start of your presentation how the framework of those 4 central domains of symptoms, structure, function, and knowledge, how are those? How was that framework generated at the beginning, into which you organise your data?
Yeah, so we used a reflexive thematic analysis, which is a bit more of a flexible approach where you look at the data and you're looking to see what themes you can create from the data. So the first step was really becoming really familiar with the data and approaching it with that research question in mind about what does need confidence mean to these people, and then going through the data and using more of an inductive coding approach. So trying to see what themes you could find in the data versus bringing an actual set framework or code book in and coding from there. So it was really letting the data kind of speak for itself. And obviously I came in with a physio lens. So it's really, I suppose, from my eyes that we've seen this.
So we've got a couple of questions for Curtin, and they're the same from Christian and from Ivan Lim. It's really about how would you change your approach to your media piece, your back pain article, Curtin, if you were to write it today?
Hi, thanks, Anne. Thanks, Christian and Ivan. Hope I'm coming through okay on sound over there. I've thought about it, and I guess one thing that was partly reassuring for me is that it looks like we're not the only group to have got feedback like this. Like Chris McCarthy published a nice piece looking at the UK experience, where we end up in this catch-22 situation where the people who already agree with us, who we really don't need to convince, clap us on the back and tell us, well done, that's great. And the people who we most need to reach out to are the ones who we fail to convince. I think one of the complications is that the kind of information that we're trying to communicate is much easier to get across in a clinic where you've got a real person face-to-face in front of you, and where if you're saying something that is counterintuitive or perhaps confrontational, I can soften that, hopefully with a bit of tone, empathy, body language. And the same concept, the same information in text can seem harsh or judgmental, even when we try not to do it. And so when I've been writing some more of these pieces for the media, one of the challenges is that my kind of innate personality is to approach this with the academic balance. And I'm essentially a fence sitter at the best of times. And yet that's not a good way to get media covered sometimes. Sometimes the more outrageous and strong the take-home message, the easier it is to get attention. So it's something that I struggle with. But to give you an example of where I suppose, some steps we're doing, I'm doing a piece at the moment with the Europe therapy, looking at, I suppose, how we handle back pain in the workplace. And so we're still doing some of the same stuff, which is like, here's some academics and researchers giving some of these messages. But because we probably have a bit more of a platform, we're trying to get some patients communicating some of that information. And really that's the big thing I suppose I would try and change as much as possible. So having virtual cases and real cases from different languages, cultures, across gender and age and so on. But even that is not exactly easy, because that depends equally on having the funding for it. For example, I'm an academic researcher. I get paid to do this work. It's part of my job. And there isn't always suitable funding to get enough patients and to take them through this in a way that they feel prepared for and supported. And it's so in terms of the current work I'm doing, I think the biggest mistake is having only the academics doing it, but that's not actually necessarily an easy thing to fix. So I can't say I've solved that problem. Sorry for the long-winded response.
Thanks.
So, Karen, to follow up, we have another question from the audience about sort of differences or changes in belief systems of patients with regard to whether the confidence of the physiotherapist in handling moderate to severe OA, whether you feel like that differs according to years of practice or private versus public, and to what extent those belief systems matter, and perhaps can they be changed if they do matter? What's your feeling about patients' belief systems and the importance of them?
So this is one of those ones, Haxby, where I feel I should shut up and let you answer that question. But before I before I throw you under the bus, I'll talk for 20 seconds while you can plan a better answer. In short, I don't really know if there's much data on whether the beliefs of either the patients or the clinicians in public and private differ. And even in terms of experience, I'm not confident. There might be data out there. So I'm going to say I'm not sure. Maybe I should read more about it. The thing that jumps out for me in the public-private issue is almost how when they've tried to change healthcare delivery, you can educate and advise, but as soon as the private system is allowed to provide some of this care, we see it's hard to change that practice. So the things that come to mind to me are in some of the countries where they've tried to reduce access to, say, knee meniscectomy when it doesn't seem indicated. It looks like some of those changes are easier to implement in a public system, and they have to be removed as an option in some of the private systems. But again, I think that's important, and it tells us how we need to restrict funding options. But I think a big part of that is making sure that that doesn't end up being seen as purely big government cutting our budget, because otherwise what you can end up is that the public system, which might be providing quite evidence-based care, is seen as the cheap yellow pack option and not offering all the bells and whistles of maybe the private sector. So, but I admit I've gone off topic there. So this is where Haxby is going to save me, hopefully.
No, I'm going to address a question to Tara about patients' belief systems, and I'm going to circle back to your talk, Karen, about your statements and recommendations about to the patient, go easy, be careful, and in your summary slide, go easy on the education early on. And I hope I'm not taking these out of context, but Tara, do you think those are, do you think that's good advice in approaching a person from the perspective of what you've learned about people's framework of beliefs around confidence in terms of the structure, function, symptoms, and knowledge framework?
Yeah, that's really interesting, actually. I mean, who am I to say that Kieran's advice is wrong? But I can think about one participant in particular, and he was one of the ones I mentioned, Ron, and his conceptualization of confidence was all around this lack of knowledge and this lack of certainty. And I asked him at one point, I said, if you had this knowledge, if you were armed with, you knew what your pain meant, and you knew how to best manage your knee, and you knew how you should behave and what the future was going to look like, how do you think, how confident would you be? And he basically said that he would go from severely to mildly or not at all. So his whole lack of confidence was related to the fact that he just didn't have this understanding, and no one had really explained to him what was going on. So perhaps it could be really individualized. Perhaps there's some people that would really respond to having lots of that education at the front, but other people, and I remember one participant that said, oh, well, doesn't really matter, I'm just really concerned about my knee giving way on me, when I do these tasks. So yeah, I think individualized care, right? Making recommendations based on the individual and what they need.
Karen, you would like to respond to that perhaps by giving us an example of what did you mean in your summary slide there by go easy on the education early on?
Yeah, sure. I think it probably reflects a mistake I made before where, well, as any professional, sometimes we forget that our job is not to, impress people with how much knowledge we have. And I went on this local, this recent course, and here's some stuff that I find interesting. So I'm going to tell you it, whether you need to know it or whether you asked about it or not. And so, for example, I think it's important that we, see what the person wants to do. And if part of that is strongly linked to me needing to tell them some information, great. And that might be around hurt is not harm or exercise is safe. But I think especially in the early days, I've done it, and I've seen physios where we spend too much time telling people what to do and telling them the stuff we know before we've actually really listened to what they think is the real problem. And so I've gone down the road of, we'll say we know that x-rays and MRI scans can sound scary. And I've spent too much time reassuring people about x-rays and MRI scans. And then they say, oh yeah, but I wasn't worried about that. And we've wasted 5 minutes of time just because I wanted to tell them some stuff to make myself feel good.
And Maybe I could just jump in there too and just talk a bit about some of the qualitative work around pain education and so forth. I know some work that Sam and I did many years ago. A lot of people that receive education don't see it in their own context, so therefore they don't feel like it applies to them. And they say, but yeah, that might be true for everyone, but for me, it's different. And so I think a really important thing is, as you've both been saying, is really contextualising the information that you're providing to the patient. And then the other important thing is that you don't believe something until you've experienced it yourself. And so I know a lot of Peter O'Sullivan and your work, Curtin, is around providing experiences for the patient that affirm those aspects of education that you're trying to deliver for them. So, you know, if we say that better sleep helps pain, then once they have better sleep, they realise they don't have pain, and then they believe it. So it's really hard to tell people things unless they have the opportunity to do the behavioural change and experience the consequences of that. So Haxby, do we have any more?
Well, it's 12:29.
Oh, right. We're almost done anyway. Yeah.
Yeah. So perhaps, yeah, do I like to wrap up?
And Curtin, thank you so much for coming on. I know it's is it like 1:30 in the morning there in Limerick?
Yeah, it is, but it's fine. You know, we finished having the kids, but the odd time of getting up in the middle of the night reminds me, you know, about what it was like having the kids. So it's all good.
You're off night clubbing now, then, are you?
Even in COVID times, my clubbing days are over.
No, that's right. Well, thank you.
Okay, take care, everybody.
Thanks again to all of our chairs and all of our panelists for that great session. We've come to our first break for the day, our morning tea. Just a reminder to everyone that we will have our second lot of 3-minute theses presenting at 10:40. So I hope to see you all then.